Dr. Adil, you can start if you wish. We have few seconds more to. Okay. Okay, Dr. Adil.
Bismillahirrahmanirrahim. Welcome everyone. Dr. Randa, Dr. Walid, Dr. Saad Mahdi, Suwaid Aswa. I would like to thank all the co-founders of this group, Media Online and the course. It's really helpful to everyone who's practicing anesthesia and pain everywhere, especially in Egypt, Middle East, and even Asia, a lot of areas around the world. Today we'll have first lecture with Dr. Walid Riyad. Dr. Riyad is a consultant anesthesiologist and intervention pain physician at the Cornish Hospital, Abu Dhabi, UAE. And he has multiple certifications from Egypt, Saudi Arabia, and Canada. He obtained his subspecialty training in interventional pain management from Toronto University, Canada. For the last 5 years, his main focus in interventional pain management of obstetrics as well as gynecology. He is doing a lot of interventional procedures, especially under ultrasound, because of the nature of the patient, pregnant patient, this situation there. He has a lot of publications and research papers. If you know the incidence of chronic pain after cesarean section, chronic pain post-surgical pain, 15% at 3 to 6 months after cesarean section. And if you know the severity of chronic pain after cesarean section of 6 months, 6 for severe cases, and 23% moderate cases, and 49% in mild pain. So you realize this is really a problem. And by attending the lecture of Dr. Walid today on persistent pain post-cesarean section and childbirth, you will be definitely know a lot of data that will improve your practice. I want to ask Dr. Walid, please, can you start with that?
Thank you very much. Bismillah ar-Rahman ar-Rahim. I'm going today to speak about an unappreciated source of pain for patient suffering. I'm going to speak about persistent post-cesarean section and childbirth pain. 3 weeks back, I discussed with you the post-operative pain control after otherwise we'll have a lot of consequences. One of these consequences is occurrence of persistent post-surgical pain. Just persist for so many years and definitely affect the lifestyle of our patients. Last week, Professor Helen in this group, she presented, sorry, can you hear me? Hello, can you hear me?
Yes.
Yeah, okay. She presented a persistent post-sternotomy pain or thoracic pain. So it's very clear to understand there is a post-cesarean section pain. But if there is any pain after normal delivery, yes, of course. I was aware personally about this problem, but I was not aware about the instance and magnitude of this problem till I start accepting referral from my obstetric colleague. Then I saw how much patient suffering silently.
Dr. Walid, is your sharing is started?
Sorry?
The slide is moving? The slides are moving?
No, it's not moving.
That's fine.
Oh, okay. That's
Thank you.
So, okay. So in my lecture today, I'm going to start with the introduction. Then we'll speak about the instance of pain after cesarean section and spontaneous vaginal delivery. Then we'll discuss where this pain is located and how much the pain is severe. Then very important, how the mechanism of acute pain transition to become a chronic pain and become a chronic problem. Then how predict about this condition and how to prevent patient from going in this difficult pathway. Then I'll speak about how can we treat this patient either conservatively or with interventional treatment. Then I'll end up with the management of some of my real cases. So I just give you a summary about the cases for today. So case number one is a 32 years old lady, which delivered by cesarean section 18 months before I saw her in a private hospital. Her surgery was a complicated surgery, long surgery. And after 10 days, she has another surgery. She was not able to tell me the details of her surgery, but I understand that she has an hematoma evacuations. And her post-operative course was complicated with severe abdominal pain for a period of 2 months or more. Same pain started to subside, but another flare-up of her pain was in the right inguinal area. Pain score, when I saw her, it is average between 5 to 8 over 10. And with examination, there is a decreased sensation to cold over the groin area. And most important for me is the presence of positive Carnet sign. So Carnet sign is a very important sign to differentiate between abdominal wall pain and intra-abdominal pain. It's a very simple test. So you put your area over you put your hand over the area which is a patient having pain, then ask the patient to flex forward. Means that they are asking the patient to put the abdominal wall muscle into an action. If pain decrease, this is intra-abdominal cause of pain. If pain increase, this is abdominal wall pain. And this is very important sign. We have to do it before taking the patient into OR for any diagnostic block. So she has a positive Carnet sign, means that her pain is generating from the anterior abdominal wall. And diagnosis for this patient is ilioinguinal and iliohypogastric neuropathy. Case number 2. This is a 35 years old lady. She has cesarean section 5 months before I saw her. She is complaining about the anterolateral severe burning pain in the right thigh. This is a patient own drawing. I just give them, all patients, I give them a pain diagram, ask her to draw where is her pain. Pain in the right thigh, lateral and anterior. It never reaches the knee. She has no back pain. On examination, there is a numbness and a hypothesia in this area. Average pain score is 6 to 7 over 10, and she only uses a loose clothes, and she can put any tight band. So basically, there is nothing can touch her skin. And diagnosis for this patient is a condition called myalgia parasitica, and we'll come to explain this later. Third case is a 34 years old, a lady have a cesarean section 2 years ago. She is African-American lady, huge lady, BMI of 46 with big pendulous abdomen. She has a persistent severe pain 7 to 8 in the right lateral part of the cesarean wound. The referring procedure told me that absolutely there is nothing wrong with his abdomen. Intra-abdominal causes are totally ruled out. Seen by many physicians over the last 2 years, but there is no different diagnosis. So her GP put her on high dose of narcotics. And with narcotics, she has a severe sedation. She stopped working because she always sleepy because of the sedation. And last 6 months before I saw her, she was on a disability program. So diagnosis of this, sorry, I have a difficulty with the computer. Okay. Case number 4 is a 35 years old patient, has spontaneous vaginal delivery 3.5 years ago. She has severe pain in the scarf episiotomy. Pain exaggerated with water flush, and she has superficial dyspareunia, no relation for the last 3.5 years. On examination, there is a tender episiotomy. There's allodynia over the scar and over the whole perineum, and there is a posterior fourchette tender point. And the diagnosis of this patient is persistent post-episodic scar, neuropathic pain, and posterior fourchette pain of fourchette neuroma. So I'm going to discuss this patient, measure this patient in detail at the end of the presentation. So chronic post-surgical pain is a major problem. It worsens the quality of life for many patients. She has a definite diagnosis. We need to have to fulfill this criteria before telling this patient have we label this patient as a chronic post-surgical pain. So pain usually develops after surgical procedure. There is no other cause of pain. And it is not an exaggeration of a pre-existing painful condition. And it persists for a longer period than expected. So if you fulfill all these 4 criteria, this is considered a chronic post-surgical pain. So minimum duration to give this diagnosis is 2 months, but the majority of people say that observative architecture between 3 to 6 months, depending on the duration of post-operative inflammatory process. So I usually don't accept any patient less than 2 months, but the majority of people come after 3 months. Some people come very, very late. So as we all know, the frequency of cesarean section have much increased over the last few years. The recommendation of WHO is 10 to 15%. I discussed this in detail previous session. But the incidence is around 27% in Canada, 32% in USA, and 51.8% in Egypt. And previous lectures, I gave this why we are facing these high numbers. So in USA, the number is around 1.24 millions in a year. I think it's almost same number in Egypt. The incidence of chronic post-surgical pain in cesarean section can be as high as 56% of the patients. One of the most common problems is ilioinguinal hypogastric nerve injury. So the incidence after 2 years is 32%, meaning that 1 on every 3 ladies have a cesarean section under transverse incision, they have an injury of the inguinal hypogastric nerve. 7% of these patients are having a suffering of severe pain up to 2 years after surgery. This table shows you the incidence of chronic pain after cesarean section. So in 3 to 6 months, it's usually, there's too many articles here, but in 3 to 6 months, it reaches up to 56%. 6 months to 1 year, it is around from between 4 to 19%. And at more than 1 year, it can reach up to 35%. So I was speaking about large number of people suffering from this problem. The same was happened after childbirth. We know childbirth is a normal process, but there is an instrumentation, there is a surgical intervention, there is episiotomy. All of this will lead to a persistent pain between 4 to 10% for women after 6 months or more. So the author of this article published 2010 says that it may be related to the perineal trauma. So if we look to this, the severity of childbirth pain. So most important to look here to this on the left here, around, we can say 8 to 10% having a severe pain, means that pain score above 7. And this means that almost 100, by our calculation in Egypt, around 100,000 new patients every year who are suffering from this condition, and they are not receiving the adequate treatment for their problem. Where this pain is located? So after cesarean section, there is 3 places you can find these conditions. So either related in the wound itself, or in the pelvis, or in the back. And very important, I always stress on that the back pain is not related to the spinal or epidural anesthesia. In healthy patient, yes, if you have a diseased back and you put a needle, this may exaggerate the occurrence of, exaggerate the pain. But if you have a healthy back, it's not related to neural axle block. Actually, there is some study shows that the back pain in healthy people is more after general anesthesia than the regional anesthesia. After vaginal delivery, pain can be either in deep in the abdomen, in the pelvis, in the buttocks, or in the genital area. The risk factor for developing a chronic pain after cesarean section may be related to the presence of anxiety or depression, more common in young obese patients, and more common in prolonged procedures. Also, general anesthesia and severe acute postoperative pain increase the incidence of chronic presence pain, and presence of preoperative chronic pain in a different condition also lead to the increased incidence of chronic post-cesarean section pain. So if you look to these all factors here, these only two factors are under our hands. The rest is we have no control. So general anesthesia. So as we discussed last time, as much as we can, we should educate the patient. We should give clear instructions that general anesthesia is not good after for cesarean section. As much as we can, we should do regional anesthesia. And it's very important to have decrease the acute postoperative pain, regardless how much patient pain use, because pain threshold is different. So some people are settled with 1 morphine, some people are settled with 5 or 6 morphine. We cannot judge the people. We have to treat their pain. If we are not doing that, the end consequences is clearly that the chronic pain is going to happen, and the patient is going to suffer for a long years. Risk factor after vaginal delivery may be related to the prolonged second stage of labor, difficult labor, assisted vaginal delivery with or without episiotomy. These two publications here telling you that the risk factor is not related to the tissue trauma itself, but it may be individual predisposition. I totally agree with that. I saw so many people that I read their notes, vaginal delivery was very normal. And some of them, I know their obstetrician, I know how they operate. Very simple. They have no issue with the surgery, with the delivery, but still they have the most severe pain I ever saw after normal delivery. It means that there is an individual predisposition factor in some patients. Okay, so what are the etiology for these conditions? So persistent pain may be related to the nerve injury or pelvic adhesion or scar problem. So nerve injury, the nerve can be entrapped, nerve can be compressed, nerve can retract it. All of these factors can happen with difficult surgery or ungentle surgeon, so, or related to the pelvic adhesion. If you look to the MRI, this is one of our patients. If you look to this MRI here, this is the uterus. And uterus is totally adherent to the anterior abdominal wall, severe adhesion to the anterior abdominal wall. This will give a deep pelvic visceral pain. So some of these patients cannot, so adhesolysis is the treatment. We ask them to do adhesolysis. But sometimes the surgeon gives us the word that a patient have a frozen pelvis, meaning that even with the scopes, they cannot see anything. There's severe adhesion, they cannot go in. And the patient will be with this condition also only with treatment, it's also treatment with the pain physicians. The surgeon said, well, I cannot do anything. And these patients stay with us for a long time. Particularly, these patients have this condition for 11 years. Or pain can be related to a scar, so either neuropathic pain or neuroma of the wound. Why pain from acute pain change to a chronic pain? There is two mechanisms for that. We have a peripheral sensitization and we have a central sensitization. Peripheral sensitization, when the patient has an acute severe pain, there is a lot of inflammatory mediator like prostaglandin E2, bradykinin. This will stimulate the G protein and tyrosine kinase receptors in the immune system reserve manner. The second stage is the phosphorylation of the receptors through different pathway. The third stage is the change of the threshold and kinetic of the receptors, means that they are working at a faster pace. At the same time, there's activation of the immune system with the invasion of the dorsal root ganglia, DRG, with the macrophages. If the condition is not treated in this situation, the condition will change into a central sensitization. A central sensitization means that stimulation of the NAMDA receptor and tolerant receptor in the dorsal spine neurons with increased excitatory synapse and decreased inflammatory impulse, causing amplification of the noxious stimuli. Same time, there is a structural changes in the dorsal horn, in the glial system of the dorsal horn, with the release of more chemokines and cytokines. This table here, published in 2014, summarize both central and peripheral sensitizations. So peripheral sensitization is a primary hyperalgesia, it's a transient, it's confined to the site of injury, and there is altered thermal sensitivity. When we touch with ice, the patient will say that there is, yes, there is more or less temperature compared to the other side. But second central sensitization, there is secondary hyperalgesia, is long-term, spread outside the site of injury, and there is allodynia and hyperalgesia. When we touch with ice, there is a severe pain. When you touch with a simple needle, there is exaggeration of the pain. Of course, both of them, there is a hormonal change, neural changes, but in the peripheral sensitization, only in search involvement of the immune system, and in central sensitization, there is glial involvement, means that structural changes in the central nervous system. This is here very difficult to treat. So if the patient comes with central sensitization after 3 or 4 years, the chance of recovery or suppress her pain is usually very, very difficult. We try our best, but we cannot promise. And that's what we always say to the patient. Can we predict occurrence of persistent post-surgical pain? Yes. There is this risk index scale, which can give you an idea about the occurrence or the incidence of persistent post-surgical pain. So the scale of 5 points. So each point each item has 1 point. So if the patient has psychological stress over the last 1 month, 6 months, this is 1 point. If there is a pre-operative pain, 1 point. If the pre-operative pain distant from the operative site, it's another point. If the pain score is 5/10 over the 1 to 5 days after post-op, it's another point. And if the patient have one of these two, have a sleep disorder, tachycardia, exhaustion, dizziness, tremor, misunderstood, taking sedative, you give also 1 point. So the score is between 0 to 5. The incidence of chance of chronic post-surgical pain is ranging from 12% if the patient score is 0, increase to 82% if the patient score 5 or score 5. Can we prevent? I think the prevention is always better than the treatment of this condition. So we can prevent by prediction of the questionnaire. We can use minimally invasive procedure as much as possible. We always ask the surgeon to be gentle with the tissue. And very important for us is the preventive analgesia. Neuroaxial block is the most preventive treatment for the occurrence of persistent post-surgical pain. Wound infiltration also help. Use of continuous installation of local anesthetic and intraperitoneal installation is very good. And recently, use of gabapentin before and after surgery. Gabapentin for cesarean section is the safest medication from the anticonvulsants, which has a good safety profile. We can use it during pregnancy and during lactation. There is kind of treatment for persistent post-cesarean section and delivery pain. We have a medical treatment, conservative, we have interventional treatment. Medical treatment in the form of lidocaine patch, tricyclic antidepressants like amitriptyline or nortriptyline, amitriptyline have a more safer profile during or more studied during pregnancy and lactation. Nortriptyline less safe but not much studied. Anticonvulsant most commonly used with us is gabapentin because it's safer during pregnancy. NSAID, short course of NSAID, non-steroidal anti-inflammatory can be used. And lastly, use an opioids. And most safer opioid used during pregnancy and in lactation is the oxycodone. So the medical treatment is shared between us and obstetrician and the GP. So before patient reach to us, he actually can usually saw between 3 or 4 of our colleagues from different subspecialty, and some of them start them on this kind of treatment. If the condition is subside, usually they do not reach to us. If not subside, we have to move to the second stage with the interventional treatment. And we have a lot of procedure can be done for this kind of patients. So first, if the patient have an anterior abdominal wall problem, we usually use a fascial plane block, either diagnostic or therapeutic. So rectus sheath follow midline pain, transverse abdominal plane block, tab block, or quadriceps bora block. So we discussed this before, and tab block used only for the anterior abdominal pain. If a patient has a visceral pain like an adhesion, we have to resort for the QLB. If we can diagnose a nerve and we do a treatment for this nerve, so we can do a specific treatment for the iliacal gastric nerve, for lateral femoral cutaneous nerve, for genitofemoral nerve, obturator and dipudendal, all these nerves can be blocked. Or we have a scar, we can do a scar infiltration or scar adhesolysis. We can give a treatment for neuroma if we have a neuroma as a cesarean section of the perineum. If the condition is not controlled, we go further step with the sympathetic block, like lumbar plexus block, superior hypogastric plexus block, lumbar block, depending on the site of the problem. We can do epidural steroid, either coder intraluminal for this condition. Lastly, we can do DRG, dorsal root ganglia, radiofrequency ablation, or we can do DRG stimulator. And last step is peripheral or spinal cord stimulation. So we have a lot of modalities for the treatment, depending on the patient condition. Some of these modalities are very simple and easy to do. Some of these modalities are difficult to do. Some of these are very expensive. So the patient, depending, we start with the simple and we go much higher depending on the patient condition. So I'll go back with these cases to tell you what I usually did for these 4 cases. So you remember the lady with iliacal and hypogastric nerve injury? So I booked this patient for a diagnostic / therapeutic iliacal nerve block. So this is a very simple block for us. So if you put your high frequency probe over the iliac crest, this is the iliac crest here, you will be able to see these 3 lines here. This is the muscles of the anterior abdominal wall. We have an external oblique, we have an internal oblique, we have a transversus abdominis. Between internal oblique and transversus abdomen, around 1 centimeter from the iliac crest, you'll find this bob here. You'll find a deep circumflex artery, this is the here, and the 2 nerves around it. So inject these 2 nerves in this area. There is another area here you can see the same. You will see 1 artery and 2 nerves. This is the subcostal and this is far. So this is not the correct area. The correct area is here. And you can do it in plane approach from the umbilicus to this area, or you can do it out of plane approach. So usually we prefer to do out of plane approach because it is less painful to the patients. So for this patient, I injected here with 4 ml bupivacaine, 0.25% plus 40 milligram dimetrodol. And pain disappeared. And usually I follow the patient 2 weeks after she didn't come for the follow-up. I phoned her, she is not answering. Patient came after 7 months with the return of the same pain. I said, where you were in 7 months? Everything was okay. Why I should come? I'm very busy mom and I'm working. I don't have time to come. I said, okay. So I injected here same thing. I said, if it's working for 7 months, I will do it again. So I injected here another time with the same bupivacaine and dimetrodol. And I said, okay, I need to hear from you within 1 month. She didn't call again. We managed to call her mother after 2 months and she's okay. So after 2 injections, pain disappeared totally. This is the injection point here. This patient with myalgia parasitica. Myalgia parasitica is a compression of the lateral femur cutaneous nerve here. And give you typically lateral and anterolateral pain because it has an anterior branch, it has a lateral branch. So usually give anterolateral pain. This is the ultrasound usually can get for the nerve. So you put the ultrasound probe transverse 1 or 2 centimeters below the ASIS, anterior superior iliac spine. You find the sartorius muscle here, another muscle here called tensor fasciae lata, and there's a fascial pocket here. This pocket contains the nerve. It's a very small nerve. So I did for this patient a diagnostic lateral femorocutaneous nerve. I injected 3 ml of bupivacaine. So the pain totally disappeared after 8 hours. Then pain returned back within 24 hours. At this point, she said to me, okay, my leg pain is disappeared, but I noticed that there is a pain in the groin. And as you remember from the pain, I said there is a pain in the groin. Ilioinguinal is a very common problem for us. So I booked this patient again for a therapeutic lateral femorocutaneous nerve block and ilioinguinal inhibitic nerve block. So this is a ilioinguinal inhibitic nerve block, and here is the needle for the lateral femorocutaneous nerve block between the sartorius and tensor fasciae lata. For both block, I total 8 milligram dexamethasone and 8 milligram bupivacaine. I follow patient after 2 weeks. There's no pain. Next follow-up, pain totally disappear and problem solved. The lady with scar problem, lateral scar problem, which has a big abdomen. I asked the patient to raise her abdomen up with severe pain. Just asked her to lift her abdomen. I scanned the scar, which is the lateral part of the scar. I just want to show you this. This is published last year only. I saw this patient 3 years back. So this is how the neuroma appear in subcutaneous tissue. There is different shape for neuroma in subcutaneous tissue. This is our patient here. So you can easily see that the patient have a subcutaneous neuroma. It's only one tender point. You have to look for it carefully. It was, I'm sure this was very difficult because the patient was so obese, so you have to, and she has a lot of pain, so people are not paying attention to do exact ultrasound scan of this area. But if you do good scan, this is what we get. So we get a subcutaneous scar neuroma. And this is what I did. I injected the neuroma with 5 ml Marcaid with 80 milligrams of Medrol. And this is my needle here. And the pain totally disappeared. In one session, pain totally, actually in 5 minutes, patient totally disappeared and never returned after that. So the patient was suffering for 2 years. Our treatment was very simple if we pay attention to what we can do. This is a lady with the last patient I'm going to discuss today. It's a lady with the pain episiotomy scar with superficial dyspareunia and neurulation for 3 years. I told her I will do injection for the scar and for the posterior fourchette. Posterior fourchette, she has a neuroma in the posterior fourchette. So in the day of surgery, I was not able to touch her perineum at all. Usually I did good examination in the OR, but I was not able to touch it because it's severe allodynia. So I have to do a pudendal nerve block. So all pain physicians are trained well to do abdominal nerve block transgluteal, but it's not suitable in most of our cases because most of our cases are in left-footing position. So we have to do a transperineal pudendal block. It's a quite simple technique if you know how to do it. So you bring your high-frequency probe in a transverse scan, mid-area between the clitoris and the perineum and the anus. You put your scope here. Over the transverse perineal muscle, this area here. So you put your scan in this area. Carefully looking for the bone here. This is the ischioprosody. And you start your Doppler. In this area, you will be able to find a pudendal artery. Next to pudendal artery is the pudendal nerve. So because of this area, personally I don't like to inject out of plane, or it's difficult for most of my patients are big, so I'll not be able to do in plane. So I rotate the probe in the longitudinal view and inject like this from anterior to posterior. So in this patient, I block her first, her pudendal nerve transperineal approach. Then I did left transperineal pudendal nerve block, waited for 5 minutes till perineum all are anesthetized. Then I'll inject a neuroma. This is a neuroma here. I inject the neuroma under ultrasound with 5 ml bupivacaine. Then scar in this area of the scar is here. I use long spinal needle. It's again under ultrasound. I go inside the scar and break this fibrosis with 12 ml of Marcam 0.25%. And I wait for 2 minutes. I ask the patient if there's any pain. She said no pain after that. I saw her with the husband after 1 month. There is actually no problem. So pain disappeared and dyspareunia also disappeared. It was a quite simple treatment for a problem with 3.5 years. So in conclusion, persistent post-cesarean section pain is a fairly unnoticed problem, which has a negative impact on the quality of life of our patients. Awareness with the problem will help to solve it. Iatrogenic neuropathic pain is the most common type, and we have to avoid a lot of nerve damage during surgery. And interventional pain treatment is the best option for patients with moderate to severe pain. And thank you very much.
Thank you very much, Dr. Walid. Can we start, please? We could start the video.
You can start the question now, if you don't mind, please.
Can you start video, please? Allow me to start video, please. Thank you very much, Dr. Walid, for this info.
Sorry.
Yes. Thank you very much, Walid, for this informative lecture. And we have some questions here. I want to start first with the attendees' questions.
Yes, please.
The first question from Dr. Muhammad Khamis is asking, is repeated injection of local anesthetic can relieve chronic pain?
Yeah, this chronic pain has no treatment. Chronic pain have only symptomatic treatment. There is no cure from chronic pain. So you have to do a repeated injection till the nerves are subsiding, stop firing some impulse. So there's no treatment for chronic pain. You are only doing a symptomatic treatment. And repeated injection is a common for us. So always patient coming every 6 months to 1 year to have the second injection. That's repeated.
We have another question. Dr. Assam is asking about bilateral tab for pain or bilateral QLB. Which one? You prefer tab or QLB or bilateral? Which one is it?
Okay. So usually the persistent post-cesarean section is not bilateral. It's always unilateral. And If I have an involvement of the viscera, so I'm going to do a QLB. If there is no involvement of the viscera, TAP will be enough. And TAP is much easier than QLB, and we discussed this last time.
Yes. To complete this picture, what is the medicine you gave in QLB and that duration? This is another question of Dr. Khamis.
Okay, so we have to, so this is not a somatic pain. This is a very important point, guys. This is not a somatic pain. This is a neuropathic pain. A neuropathic pain, if you give local anesthetic plus dexamethasone, it will stay for months, not like somatic pain will stay 1 day or 2 days. So the injection, it can last for 2 months, 3 months, 4 months, 6 months. The same you give for the somatic pain. For post-operative pain, to stay for neuropathic pain for more than 3 or 6 months, depending on how much the absorption. So we use, personally use bupivacaine and dexamethasone, most of the blocks.
Thank you. We have a question for our friend, Dr. Yasser Zahloul. We miss him too much a few lectures ago. His question is, what is the best approach for acute pain after cesarean section to minimize the chronic pain?
So the best approach is start with intraoperative. So you have to have a regional block. And for post-operative, we have to have, again, another regional block. So we prefer to have a spinal and QLB plus a regular non-steroidal and paracetamol and PRN morphine, as long as the patient can take. So we don't make the patient receive 2 morphine, this is enough, it will become addict. This is not actually a scientific talk. We need to block her pain. So spinal, QLP, regular NSAID and paracetamol. On top of this, we can add morphine as needed. PRN.
Okay. I will include my questions. Need to include also some questions of the attendees. Would you prefer to start with medication or interventional procedure?
Okay. So actually, for chronic pain, every case is individualized. We cannot dictate one treatment for everybody. So as I saw the patient, so some patient it will be difficult for them to have a medical treatment because, for example, they are working. Most of our medication giving business. Mother, she need to take care of the baby. So we cannot put the mother to sleep. Most of the medication will put the patient to sleep 12 hours, 14 hours a day, dizzy. So in this situation, we prefer having intervention treatment. Some of the patients are afraid from needles. They said, no, we don't need any needles. We take a treatment. So usually the active people are looking for intervention treatment. The people who are afraid, they usually go for medical treatment. Personally, if the condition is not severe, I usually start with medication for 1 or 2 weeks as a trial. If it solves the problem, that's it. If not, I will do an intervention treatment. But some people say,
yeah, please.
But some of the patients have severe condition. In severe condition, it's very difficult to start with medical treatment. You are not going anywhere. You have to start directly with intervention treatment depending on the condition of the patient.
But in case of breastfeeding or lactating mother, you start even with medications, or you prefer to go for intervention?
So it depends. So if I'm not going to give heavy medications, so we can give, so because in cesarean section we give medication, correct? For paracetamol and NSAID, there's no problem. Oxycodone also no problem, but not a heavy dose, not a small dose only. A small dose, if the patient subsides we subside her pain with a small dose, it's good. But if the patient pain is severe, and I know that I'm going to give high dose of medication, I'll offer her various intervention treatment.
Okay. Another question, how to prevent central sensitization or treat it if it happens?
Okay. So treatment, as I said, it's very difficult. It's have a structural change in the central nervous system. So we have to also use a central medication. The most good treatment for central sensitization is NAMDA receptor antagonist, means that ketamine, because it's work in NAMDA receptor. So non-receptor antagonist ketamine is very good drug. So you usually use a ketamine infusion plus medications that work centrally as an anticonvulsant. But this can decrease the pain, but usually it's very difficult to stop the pain once it becomes a central sensation. The most important point is to refer the patient very early before this problem happens. So within 6 months, 3 months, it's easy to treat. But if I see the patient after 5 years, it's very, very difficult to treat. And from first session, I always tell the patient, your condition is prolonged. I'm not expecting to finish this problem within 3 months or 6 months. Maybe we need 1 year or 2 years to maybe able to decrease your pain, but not prevent your pain.
Yes, patient expectations be considered, as you said, Dr. Walid. Thank you very much for this well-informed lecture. And inshallah, we hope to see you again in future lectures.
Thank you very much.
Thank you very much, Dr. Walid. Thank you.
Can you put sharing, please, Dr. Walid and Dr. Now we will be with the second lecture of Professor Randa. Professor Randa Badawi is a professor of anesthesia, faculty of medicine in Cairo University, and Saudi Arabia as well. She is devoted for hardworking professor of anesthesia, 30 years experience in Qatar Ain Hospital. Dr. Randa also is a teaching professor at the Faculty of Applied Medical Science in Imam Abdurrahman University in Jubail, KSA, Saudi Arabia. She has special interest in airway management and fiber optic, and she's an instructor in airway management program in Qasr Al Aini. She's also an instructor in European Restoration Council for PLS, ALS, and APLS HCC. Dr. Randa, she's keen on attending sessions and courses and temporary journal, and is also attending aeromedical education course. Dr. Randa also, she's an examiner of anesthesia fellowship and emergency medicine fellowship. We expect by attending Dr. Randa lecture on anaphylaxis, all of our colleagues should understand and diagnose what is anaphylaxis, what is anaphylactoid reaction, what is the most drugs that may be associated with intraoperative anaphylaxis, what is serum tryptase, how to prevent and how to treat anaphylaxis. Please, Dr. Randa, can you go?
Good evening, everybody. Thank you, Dr. Adel, for the very warm introduction. Today, I'm going to discuss anaphylaxis. I'm going to cover the following items: anaphylaxis meaning, causes precipitating anaphylaxis, risk factors, how to treat this situation. Anaphylaxis is an exaggerated response and life-threatening condition manifested by generalized or systemic hypersensitivity reaction, mostly due to antibiotics. It's mediated by hypersensitivity due to release of the IgE antibody. It occurs within minutes of exposure to a specific antigen. It's characterized by life-threatening, rapidly progressing deterioration in airway, breathing, and circulation, may be associated with skin manifestation or mucous membrane. This is the least important, but it clinically may be so prominent, but it, as regards clinical importance, is not that significant. That can occur rapidly from irreversible or respiratory or circulatory shock. The incidence of anaphylaxis during anesthesia has been estimated to be 1 every 500,000 or 1 to 20,000. The most common factors incriminated in the occurrence of anaphylaxis under anesthesia is the neuromuscular blockers, antibiotics, also non-steroidal anti-inflammatory aspirin are very common. Latex is also important factor. How to diagnose? Certain criteria should be fulfilled. Unexplained hypotension, unexplained bronchospasm, unexplained tachycardia or even bradycardia, angioedema. By angioedema, the skin manifestation characterized by redness, erythema. This is at the level of skin. This is due to capillary leakage, which is part of the pathology of the situation, which is related to the histamine release, which leads to vasodilatation and increased capillary permeability. So at the level of skin, this causes the erythema and urticaria reaction. When this capillary leakage goes into the deeper tissues, this is called angioedema. Example, edema of the eyelids, edema of the tongue, and this is very serious sign. Whenever you find a face involvement, this is a really life-threatening condition, and it may indicate an impending death if not properly managed. So angioedema, not always it occurs, but if it occurs, it's a very serious complication. We should take it a good observation to pick it early. Maybe unexplained, the patient presents with sudden cardiac arrest, where the causes is not unknown. Cutaneous manifestation is the least important. As regards the pathophysiology, it's an autoimmune disease of the IgE type. Here, there is a release of inflammatory mediators from the mast cells and basophils triggered by an allergen. This leads to interaction with cell-bound immunoglobulins of the IgE category. However, it might be a non-IgE or non-immune release also, but this is rare. The majority is based on autoimmune. This leads to release of mediators, histamine and leukotrienes. Histamine leads to vasodilatation and increase in the capillary permeability, leading to edema and decreased venous return. As we said, trigger factors, it might be in general food, this especially in children or in adults. It's mainly related to drugs or sting bites. The presentation differs. It's very rapid. It occurs within 30 to 35 minutes after food administration. It can occur following 10 to 15 minutes in case of insect bite. The worst scenario is with drugs, as the reaction is can occur within 5 minutes, and this may lead to serious complication. Whenever we face a case of anaphylaxis, how to manage? Number one, we should call for help. The manifestation arises suddenly. The patient presents with multi-system affection. More than 2 systems are going to be affected, mainly cardiovascular in the form of hypotension, tachycardia, maybe ECG manifestation of ischemia due to the low blood pressure. Even in a normal person, not a cardiac one. The patient may present with bronchospasm and increased airway pressure, manifestation of wheezes. If the patient was under GA, GIT symptoms may occur in the form of diarrhea or nausea or vomiting. So it's multi-system affection, skin manifestation, we said it before. So whenever we diagnose, we have to start immediately without any delay to manage. Number one, and the most important, is to call for help. Whenever you face any kind of problem, you have to call for help. And not the team. If you are under GA or in the OR under anesthesia, you have to stop any factor which might be the triggering agent. If the surgery wasn't started, it's advisable to cancel it if it's possible. It's advisable not to start the surgery. Then start to resuscitate the patient and let the CPR trolley stand by, because cardiac arrest is quite common in this situation if not properly managed. You have to remove all the potential causes if it's possible. If you are giving a colloid solution, stop it. If you are putting an antibiotic infusion, withdraw it. If anything is going on, you have to stop it. If you give a bolus drug, it's no way to withdraw it. Intravenous colloids should be considered as a triggering agent during anesthesia. So you have to take care. If you are running a colloid, you should withdraw it. You should shift if under GA and you cannot postpone the surgery. You should shift to the inhalational anesthetic agent better than the IV, because the IV may be incriminated. So although it's not common, but it's better to use the inhalational as they are not incriminated in this situation. To start management, this is a critical ill patient. So we are going to follow the ABCDE approach. Number one, whenever you are resuscitating a critical ill patient, you should administer 100% oxygen. This is in the very first beginning. Then we have to secure the airway as regards A. This is a life-threatening condition, especially if you find a clinical sign suggesting an airway involvement. If the patient is under regional, you can pick it from his voice. If there is hoarseness of voice, this means that the larynx is involved. But if the patient is not awake, you may find another symptom. So if the patient was not intubated, maybe you give in the preoperative antibiotic and he developed the anaphylaxis. In this situation, we are going to manage, and accordingly, we might postpone the surgery at all, but we have to save the life of the patient. I have to secure the airway. How to secure the airway? Definitely by endotracheal tube, because supraglottic device has no role in this situation. It will be difficult to insert. Then when the situation deteriorates, you cannot ventilate through the supraglottic device properly because they develop bronchospasm in addition, which is a contraindication for the use of supraglottic devices. This is as regards the A, secure the airway with endotracheal tube. The trick is too early. This is the most important issue, because if you wait, it will be more difficult and the situation will be very difficult. So you have to secure early, especially when there are signs suggesting of the anaphylaxis, especially if angioedema is imminent, if the eye are swollen, or the lips, or there is hoarseness, or the manifestation of multi-system affection, meaning that anaphylaxis is going on. I have to secure the airway early under any condition. It's better to call for an expert anesthetist to intubate such patient, and he should be ready with the difficult airway chart. This is as regards the A. As regards the B, we have to check the breathing of the patient by the look, listen, and feel. Look for if he was spontaneously breathing or he wasn't under anesthesia yet. You have to check his rate. You have to expose his chest to see bilateral chest rise, the rates. You have to look at the monitor as regards his SpO2 and tidal CO2, then manage accordingly. Auscultate, look, listen. You have to auscultate. You may feel wide scattered wheezes. However, if you didn't hear any wheezes, this is not a good sign. A silent chest is an eminent sign of indicating severe bronchospasm. And then check the blood pressure of the patient. If the patient is hypotensive, also if the patient is intubated, look at the airway pressure. You will find it elevated. You can find on the capnogram signs of airway obstruction, which is denoted by sloping fell upward curve of the capnography. This is as regards inspection, look, listen, and feel, or what's called inspection, palpation, percussion, auscultation. That we have to shift to C. We have to check for the blood pressure of the patient. Definitely, if it's decreasing, this is a very serious. This is the most feared complication, respiratory and circulatory, as they may lead to cardiac arrest for the respiratory or circulatory reason. In this situation, if the blood pressure is below 50, cardiac arrest mainly is coming. You can manage simply by elevating the legs of the patient to increase the venous return. And if the blood pressure is below 50, you have to start immediately CPR in this patient. Then we have to start drug medications. For the hypotension, the pathophysiology is related to vasodilatation. So the patient became relatively hypovolemic. So number one, I have to give plenty of fluids. So we give fluid bolus of 20 ml per kg. This can be normal saline or lactated ringer. Then you should start with adrenaline. The most important and the life-saving drug is adrenaline because it has many beneficial effects. Its alpha effect leads to vasoconstriction, and the pathology is vasodilatation due to histamine release. It decreases histamine release, which is the problem. Then the beta effect, it leads to bronchodilation, so it's very beneficial. The key is to start it early. This is the most important, and to start the adrenaline early to shut down the circle. Its alpha effect will help to reverse the drop of blood pressure as it causes vasoconstriction. The beta effect will improve the bronchospasm, and meanwhile, it will abort further release of histamine. We start by intravenous bolus. Then, if no response, we can repeat it up to 3 times. If the situation is still not responding, we have to shift to another alternative, or you can add adrenaline by infusion. The alternative drugs are vasopressin or noradrenaline, levodopa, I mean. If the patient is on beta blockers or calcium channel blockers, we may add glucagon. Adrenaline is a physiological antidote for this reaction, and we said the reason. We start by intravenous route in a bolus 50 mic IV. If the patient has an IV line, I have to start with the IV line. If the problem occurred but no IV line, I cannot find because he's shocked, shift to the intraosseous route. Provided I'm an efficient one to give in that route. So intravenous route, this is very important. Intravenous or intraosseous, as intraosseous is considered as if it's IV line. You should be expert to use that route, because although adrenaline is a life-saving, but it may put the patient in a further deterioration if you cannot manage its complications. The one who should use IV adrenaline should be an expert one. How to use vasopressors, how to titrate these drugs, and the patient should be monitored. If these criteria are not fulfilled, so you can give safely intramuscular. As regards the intravenous route, it's 50 mic IO or IV. This is how we prepare it, because this is the important. The ampoule of adrenaline of 1 milligram, its concentration is 1 to 1,000. So I have to dilute into 1 to 10,000. This means 1 milligram of adrenaline. I added to 9 milliliter of saline to make the total volume 10 milliliters. So this means that every milliliter contains 100 mic. The dose is 50 mic, so I have to give a bolus of half milliliter each time, then flush and repeated while you are monitoring the hemodynamics, meanwhile having a look on the ECG of the patient. If you exceed 3 boluses, you should shift for the infusion. This is as regards the dose for an adult. For pediatrics, the dose is 1 mic per kg. How we can prepare it? Because this is the most important, the clinical part. In pediatrics, the concentration is 1 to 100,000. So I have to dilute 1 milliliter in up to 10 centimeters. Then I can take 1 milliliter of the diluted that of the adults, 1 to 10 thousands, and take 1 milliliter and dilute it again into another 9 milliliter. So, and start to give 0.1 milli per kg. This is for the pediatric patients. Also give it by intramuscular or intraosseous. Or to maintain, if he tried 3 times and no response, you have to shift for the continuous infusion. This can be done by diluting 5 milligram of adrenaline on adding it to 500 milliliter dextrose by 5% or normal saline. This means that there is access 0. I'm sorry. 5 milligrams means 5,000 on 500. So the 1 milliliter contains 10 mics. And start infusion and manage titrate according to the readings on the blood pressure. You may alternative drugs, vasopressors, or glucagon in case of the patient is receiving beta blocker or calcium channel blockers. To return again, sorry, for adrenaline, if you are not expert or you are outside the OR, maybe you face a patient with anaphylaxis in the ward or not on the ER and you don't have monitors. So you should stick to giving the adrenaline by the intramuscular route. How to do it? It's given in the thigh, in the upper lateral 1/3 of the thigh. This as regards the adrenaline. Adrenaline should be given by a senior expert one, as it may lead by itself to death if you are not, you don't know how to manage. If you give adrenaline IV to a spontaneously breathing patient, I mean that he is not arrested, it may lead to severe tachycardia, severe hypertension, arrhythmias, ischemic manifestation. So I should know what's going on through the monitor. If I'm not senior enough, it's better to use it by the intramuscular routes. NOS, half milligram intramuscular. Other drugs to be used during anaphylaxis, definitely steroids, which are well known to be given in case of allergic reaction. The route is definitely intravenous. According to the age, if it's a child less than 6 months, you can give 25 milligram. If a child is 6 months to 6 years old, double the dose into 50 milligram. If the child is 6 to 12 years, double again the dose, it will be 100 milligram. If the patient is an adult, double again, it will be 200 milligram. This is for the steroids. The other line, which is the second line of treatment, is the antihistaminics. We can use chlorphenamine. The route definitely in a critically collapsed patient, the route is definitely IV. For pediatric, less than 6 months, 250 mic. If the age is 6 months to 6 years, give 2.5 milligram. If the age 6 to 12, double the dose into 5 milligram. If he is adult, double again to 10 milligrams. As you are administering adrenaline, breathing should improve, because in management of asthma, the last resort, we give adrenaline. So If you give the adrenaline by the intravenous route, but there is still bronchospasm, we should manage more aggressively. How to know that the patient has bronchospasm? We said that before, that it will be obvious on the monitor as increase in the airway pressure, and it will be obvious on the capnogram. The patient also on the may show desaturation on the pulse oximeter, and if he develops hypercapnia, this is the worst case scenario you can ever meet in a patient, asthmatic patient. This means that it's an imminent death. This is a life-threatening condition. So if you find an asthmatic patient and who starts to develop hypercarbia, you should intubate this patient. Don't wait, because it's a life-threatening condition. For the management of bronchospasm, first I have to exclude an iatrogenic cause for the increase in the airway pressure, as if the tube is endobronchial. So one of my confirmation is to listen bilateral for air entry, to exclude endobronchial intubation, as it may cause spasm and elevation of the airway pressure. Number two, exclude that the tube is obstructed. These are the reasons why the airway pressure is high. So it may be the tube, it may be obstructed from outside or inside. From outside, it may be kinked. So be sure that the tube is not kinked, no any obstruction in the circuit. Then you should pass a catheter through the endotracheal tube to exclude obstruction. Here, while we are managing to keep the patient at a good level of anesthesia, we said it's better to use the inhalation rather than the IV. Here, we should avoid isoflurane and this fluorine if we would like to deepen the level when the hemodynamics allows, because they have an irritating airway effect. So they are not the ideal drugs in this situation. And then you have to administer the drugs to treat the bronchospasm. What are the drugs to be used? Definitely beta stimulants is the golden standard. We use salbutamol. It's given by nebulizer. This is the first choice. We give it by a meter dose inhaler or nebulizer. For the nebulizer, it takes about, it will take an action immediately. So we have to repeat it every 15 to 20 minutes if the patient doesn't show any improvement. As regards to the dose, for child less than 5 years, the dose is 2.5 milligram. For an adult or a child more than 5 years, you should use 5 milligram to be repeated, as we said, every 15 to 20 minutes. You can try up to 3 times. Then you should shift to continuous nebulizer use or to the intravenous, as we said with the adrenaline. Try intermittent doses, no response, shift to continuous route. So nebulizer that can be given, should be given with a high flow oxygen, as nebulized drugs will not be delivered to the lung effectively if the patient is hypoventilating. This is if the patient is spontaneously breathing, definitely, or is not under anesthesia at all. This is a common recommendation. If a nebulizer is not available right now or immediately, you can give temporarily emitter dose inhaler via a large volume spacer device. Then, if no response with the nebulized salbutamol, we have to shift to the intravenous route. This is second line for treatment, second line route, I mean, for the beta stimulant. For children up to 2 years, the dose is 5 mic per kg once over 5 minutes. So I give it slowly and it's once. The maximum dose for a child less than 2 years is 250 mic. If the child is 2 to 17 years old, the dose is 15 mic per kg. It's also given once. So the maximum is also 250 mic. For adults, the dose is the 250 mic, and it should be diluted and given slowly. If this, when we give the drugs by the nebulizer, no response, I can give IV bolus. If no response, now I should start the infusion. The infusion dose is half to 1 mic per kg per minute for a child. For an adult, the dose is 5 to 20 mic per minute, not per kg. Take care. Okay. Other modalities or other drugs to be used is the ipratropium. This is an anticholinergic drug. It can be given by the nebulization in case the patient is not responding to the beta stimulant. Here the dose for an adult, we give half milligram and repeated 4 to 6 times per hour. For a child 2 to 12 years, the dose is 0.25 milligrams. Adrenaline for cases for bronchial asthma or severe spasm. Here we are covered with the dose given by infusion for the hemodynamics. The doses for in case any bronchospasm. You can start with a dose also start with a nebulizer route, nebulization. Child, you use half milliliter of the original concentrated drug, 1 to 1,000 concentration. For an adult, you use 5 milliliter of the same solution. I mean, not diluted. The original concentration, take it, then add to it the saline to put it in the nebulizer. I mean the dose, half milliliter of 1 to 1,000 or 5 milliliter of 1 to 1,000, then diluted before mixing in the nebulizer. Slow IV dose, this is the dose, 0.1 to 1 mic per kg in children, or 10 to 100 mic for an adult. Another line of treatment for severe persistent bronchospasm is magnesium sulfate. But here, in this situation, taking magnesium sulfate leads to hypotension. So if your patient is still hypotensive, don't give magnesium sulfate. This is for the general lines for management of bronchial asthma. The guidelines, but you should think what's the risk to benefit ratio. However, if the patient is improving as regards the hemodynamics with the fluids and adrenaline, but there is still bronchospasm, you may add magnesium sulfate. The dose is given by slow IV over 20 minutes as it causes hypotension. The dose is 50 milligram per kg for pediatrics. For an adult, you give 2 grams. To use, in the last we used to use aminophylline as a first line treatment. Now it became in the late stage in the list because it has a very narrow therapeutic toxic effect ratio window. So it's not advised to use it early in the management. It should be used only in severe or near fatal asthma. Loading dose is 5 milligram per kg. It should be given slowly IV over 20 to 30 minutes. You should omit giving a bolus loading dose if the patient is already on thiophelin treatment. Then give intravenous infusion. For an adult, the dose is 5 milligram per kg per hour. For a child 9 to 16 years old, the dose is 0.8 milligram per kg per hour. Less than 9 years, the dose is 1 milligram per kg per hour. Take care, the dose is increasing with decrease in the age. This as regards the drugs to be managed. How to manage the ventilation? The patient, if we face the problem intraoperatively and the airway pressure is elevating, how to manage? The risk of severe bronchospasm that the patient is not able to get rid of the expired air. So air will be trapped. So this may lead to what's called auto-PEEP, and it may lead to bilateral pneumothorax, which is a very serious complication. So we have to avoid using a large tidal volume in these patients. So the strategy will be to increase expiratory time. Why? To give time for the air to be completely exhaled. Number 2, shift to pressure control ventilation may be better, and allow what's called permissive hypercarbia may be appropriate in these patients. As you know, the determining factor to get rid of the CO2 is the tidal volume. And in this situation, I'm obliged to use the minimum allowed tidal volume just to see a good chest rise. So the patient may develop a little bit hypercarbia, but this is much better than develop auto-PEEP and barotrauma pneumothorax, which if it occurs, it might be bilateral. This is the management of the anaphylaxis.
Thank you very much. Rhonda, thank you very much.
You're welcome. Thank you, sir.
Very comprehensive lecture. And I want to relay the question of our attendees first. Mr. Saad, can I unmute you, please?
I'm not, I don't hear you, Dr.
You hear me? You hear me, Dr. Saad?
Yes, I do. Yeah, thank you.
So, Dr. Ahmed, maybe she unmuted. Can you unmute her?
Oh.
I don't know.
Dr. Randa is, she's okay now.
Do you hear me, Dr. Randa?
Yes.
Okay. There's one question here from one of our colleagues. What about the skin test, preoperative or intraoperative skin test for hypersensitivity, for example, like antibiotics? Is it reliable to do?
Definitely, you know, we are all anesthetists. You don't do a test before. We do tests, skin tests for antibiotics, but we don't use for an example for non-steroidal or for muscle relaxant. We always give the muscle relaxant without skin test. So
Yeah,
we,
the
but
question
for
about
the
antibiotics. Yeah.
for antibiotics, definitely you should do skin test before, definitely.
Okay. To comment about this point, we have a debate on our institution when to give the antibiotic, because usually the surgeon want to give the antibiotic immediately after induction of anesthesia, and our anesthetic maybe have patient allergic like rocuronium or other drugs. So we don't know which one is the reason for the allergy.
No,
So yeah.
the proper way for management by the book, antibiotics should be given 30 to 1 hour before
Yes.
skin incision. So
Yes.
it will be this is the correct way, number one. Number two, it will eliminate the debate, which is the incriminated drug, whether the antibiotic or the muscle relaxant. So, because in case of drugs, the reactions appears immediately within 15 minutes, 5 minutes also, sorry, for 5 minutes, the intravenous drug effect will appear.
There is one question here about the preparation of adrenaline inhalation.
Yes.
How they prepare that for inhalation and bronchospasm.
In case of, we mentioned in case I'm going to, we take the adrenaline as it is from the ampoule, 1 milligram, 1 to 1,000. This is the concentration. I take half milligram in case of pediatrics, while for adults, I take 5 ampoules of 1 milligram, then add to it the saline in the nebulizer and start to inhale it. It depends on the dose. The dose is half milligram of the undiluted from the ampoule of the 1 to 1,000 concentration. In case of pediatrics, the dose is half milligram. The dose in adults is 5 milligrams.
Okay. Here again, want to ask about the atopic patient. Is atopic patient at risk of?
Yes, these are the worst patients you can ever meet. The atopic patient, because the patient who is atopic or asthmatic, when they develop anaphylaxis, the mortality rate increases. So I have to be very careful while taking the history in case of asthmatic or atopic patients.
So pre-anesthesia assessment in the clinic is very important, crucial to detect patient at risk of developing anaphylaxis.
Another, I want to add, we have to, for the clinical, as I mentioned, atopic, for the differential diagnosis, anaphylaxis may be mistaken with a case of sepsis or severe asthma. So I have to watch with the patient or panic attacks or vasovagal. In this situation, if you give adrenaline, you may kill your patient. So I have to diagnose properly. Anaphylaxis means more than 2 systems involved after exposure by a triggering drug, while vasovagal, no triggering agent. So this is a category. If only skin manifestation was evident, this is not an anaphylaxis. Never to give adrenaline in this situation, because adrenaline has a great risk for the patient, as we mentioned. Also, if the presentation is only chest, respiratory, this is not an anaphylaxis also. We manage as a case of severe bronchospasm, as we mentioned how to manage.
Okay. Is there any rule for post-op observation as an exit?
Yes, definitely, definitely. If the patient is coming for daycare surgery and he develops severe bronchospasm or severe anaphylaxis, he should be watched for 24 hours in ICU unit because there is an incidence of what's called delayed anaphylaxis. If he develops, he might develop. So he should be observed for 24 hours in an ICU unit.
Or biphasic, we call it biphasic sometimes, biphasic exists from some debate about the terminology.
Also, for the academic purpose, we can, to confirm the diagnosis, you can make certain lab that's tryptase, you measure mediator of the mast cells. We take 3 samples, one at the time of whenever you suspect, but never to delay treatment to take a sample. Start resuscitation, meanwhile take a sample, then after 2 hours, then after 24 hours. That's for documentation purpose. Because abroad, they should document what's going on by solid data, not only the clinical.
I want to stress only we should inform a patient, give him bracelet in his hand, whatever, or that we bring with him every time to go to anesthesia. Very wonderful lecture, Dr. Randa, Dr. Walid, thank you, everyone, and Dr. Saad, this is much good.
Thank you much, Professor Randa and Dr. Walid, Professor Adil, for moderating this session, and excellent chance, and our panelists today, and a lot of professors here supporting us. That's why this course by all of you is supported by the Egyptian Society of Anesthesiology for personal development and for education. That great success. Our course is really very international by you and your support, and we have a mixture of obstetric, general, ICU, and pain management, which is a great chance and opportunity for everybody to study. All our lectures are stored in our Mega YouTube site, Mega Academy, Mega Medical Academy YouTube, and anybody can go back to those lectures and review them at ease. I would like to thank you very much, and next Thursday كل سنة وانتم طيبين عيد إن شاء الله, and we'll be off, and the following Sunday will be off as well. So last session for this module is next Sunday, because our first module finished next Sunday. So we'll take 1 week off, and we'll start again the Thursday after. And from myself here, happy Eid, and see you next Sunday, this coming Sunday. And thank you very much, everybody here tonight. Thank you.
Thank you very much.
Thank you very much.
Thank you for everybody.
Thank
Thank
you.
you for everybody.
Thank you.